5 seconds to read the question, pause the video, and then we'll go through the answer. Okay, so in this question, we have a 34-year-old female, past medical history of generalized anxiety disorder, and she has a headache, okay, that's been going on for the past 2 hours. We know that she's had the headache for at least 2 hours, right? So we don't know how long it's going to be. Now, the fact that it's been at least 2 hours and it's in a female, already I'm starting to think, okay, it's probably not trigeminal neuralgia, right? Because that would typically be in an older patient, and the fact that the headache's been going on for 2 hours would be very non-classic. It's also probably not a cluster headache. Like I said, that typically is going to be asked about in males. It could be, though. So let's continue to read. So the patient reports that she was in a meeting at her office when she suddenly saw stars and felt her left arm go numb. She initially thought she may be having a stroke. However, her symptoms resolved within 5 minutes. Shortly thereafter, she developed a left-sided, 8 out of 10, throbbing headache. Okay, throbbing, also one of the classic words used for migraines, right? And it's left-sided, so it's unilateral. She's been unable to eat due to significant nausea, also very classic for migraines. She requests that the lights remain dimmed in the room, right? So this is also going back to the photophobia. Her grandmother has a history of recurrent headaches, right? So family history, also very classic for migraines. Oral contraceptives are the only prescribed medication she's taking. Also, side note, OCPs are also can increase the risk of migraines. So that's another thing to remember. Vital signs and fundoscopy are shown below. So the fundoscopic findings actually look okay, right? We don't see papilledema here. If we did, we'd be thinking more about idiopathic intracranial hypertension. The vitals look okay, although she is tachycardic, and that might be because she's in pain potentially. Non-contrast head CT is unremarkable. A serotonin agonist is prescribed to acutely manage the severity of the patient's headache. Okay, so it's a serotonin agonist. So what is the drug that we're talking about? We're probably talking about sumatriptan, right? That would be the classic one that would come up first usually if we were asking about one of these, treatment modalities. Of course, there are other options. It could be ergotamine, for example. Which mechanism of action is most likely consistent with the medication prescribed? So let's just go through this really quickly. Inhibition of enzymatic carbonic anhydrase. This would be very classic for acetazolamide, right? Acetazolamide. And this would be, if we were thinking about a patient that had idiopathic intracranial hypertension or pseudotumor cerebri. Again, it doesn't mention anything about her being an obese female. There's no signs of increased intracranial pressure, right? They didn't really give us enough information to, in any way confidently say that this patient would have IIH. And instead, really, this sounds more like the patient has aura, family history of migraines, very classic photophobia. So this would probably not be the best answer. Binding to inactive voltage-gated sodium channels in cortical tissue. This would be very classic for carbamazepine. So carbamazepine, remember, classically associated with trigeminal neuralgia, right? And so again, this is very non-classic for trigeminal neuralgia for reasons we already mentioned, right? This is a longer lasting headache, over 2 hours, not the classic findings, usually going to be in an older male. Here we have a young female. So again, not very classic for trigeminal neuralgia. And then these last three options, these are all similar in some ways, and they really test your understanding of the mechanism. Okay, so in one case, we have inhibition of CGRP, right? And so we said that that's really what sumatriptan is doing. Sumatriptan is doing two things. It's going to inhibit CGRP, and it's going to inhibit CGRP through decreased firing of the trigeminal afferents, right? So that's kind of what we were talking about. And the other thing it's going to do is it's going to cause vasoconstriction, right? So those are the two things that sumatriptan is going to do. So here we can see inhibition of CGRP release from trigeminal afferents being the correct answer. Stimulation of trigeminal afferents to release substance P would not be correct, right? We want inhibition of trigeminal afferents, right? We don't want more release of substance P. In fact, we would actually want a decreased release of the vasoactive peptides, right? Because substance P is very similar to CGRP, and we want to inhibit those things. Okay, and the last option here, intracranial vessel vasodilation, right? Nope, we want intracranial vessel vasoconstriction. Okay, so just have to remember kind of, what these mechanisms are, and then why, and when we're treating it, we're usually just doing the opposite, right? So migraines cause vasodilation, release of vasoactive peptides. Sumatriptan is used to inhibit those vasoactive peptides and thereby also cause vasoconstriction.